Good morning, respected Emeritus Chairperson Sir, dignitaries, our guests, teachers, colleagues, and my dear students. We gathered here for the CCR of the Department of ENT, and on behalf of my HOD, I would like to give a brief introduction of our department. So our department the inception of our department was way back 24 years ago in the year of 2000 when the institute was getting formed. The UG curriculum commencement was done in the year of 2002 and the postgraduate curriculum commencement was in the year of 2000. As of now, a total of 27 postgraduates have graduated from our department and are doing very well in practicing ENT all over the country. We are very glad to have recently been joined by Dr. Achal Gulati sir, who is the Vice Chancellor of our institute, our HOD sir, Dr. Tarun Ojha, Professor Dr. Pratibha Vyas ma'am, and a constellation of junior faculty. We have 4 senior residents in our department and 12 junior residents at present, with a very dedicated and hardworking environment and staff. The department's data of past 1 year with an OPD of 18,300 patients with an averaging of 1,500 per month and minor OT procedures of 4,000 averaging 340 per month and an IPD of 2,000 patients roughly averaging 175 to 200 per month and major OT procedures of approximately 2,000 averaging 165 to 200 per month. So ENT is a primary specialty and like any other primary specialty, our epicenter of focus is on 4 key areas. One is holistic patient care, the second is UG teaching and its curriculum, third is PG teaching and its curriculum, and the fourth is research and its methodology. We have in our very early days of department formation established a temporal bone dissection lab where the residents can practice temporal bone dissection on cadaveric bones and also advanced ENT procedures including lateral skull base and anterior skull base. A very state-of-the-art audiometry lab where we have proton audiometries of approximately 700 per month, tympanometries, BERAs and speech therapies. We have a minor OT where we are routinely performing nasal endoscopies, oral endoscopies and laryngoscopies. In the year of 2023, we were very fortunate to have Vertigo Lab established in our department. Now we are proud to say that we are holistically performing vertigo patient management and care. We have a state-of-the-art OT to a number of 2 where we are routinely doing all the ENT procedures from basic to advanced. So far, in these 24 years, we have published about 94 manuscripts in international and national journals, and 55 papers and posters have been presented at repute platforms by our faculties and our residents. In aligning ourselves with the vision and mission of our institute, we believe in faculty development program in the era of precision medicine, and my colleague Dr. Garima Katewa has done her fellowship in cochlear implant surgery from Jaipur Hospital. Dr. Vaishali has done it in obstructive sleep apnea from MERF Chennai, and myself have done it in allergy and immunotherapy from CMC Vellore. Along with these, we have performed and organized numerous conferences and workshops, the highlight of it being AOICon 2023, which was organized last year, which is a national level ENT conference spanning 4,000 to 5,000 delegates, which was organized on a 3-day event by our department under the organizing secretary of Dr. Tarun Ojha sir. Apart from this, we have organized numerous workshops and CMEs, including cochlear implant surgery workshops, temporal bone dissection workshops, ear cons, skull-based rides, and many other CMEs. Without further delay, I would now like to start our case, which is a 35-year-old female who presented in acute respiratory distress to the Department of ENT. Since it's a slight detour from the classic presentations we've been seeing, we will first manage the patient stabilization in the emergency department doing the ABCDA protocol, followed by the patient and the case narrative. I would like to invite Dr. Abhishek Pataliya from the Department of Emergency Medicine to take this case forward. Thank you.
Thank you, ma'am. Good morning to the Emeritus Chairperson, sir. senior faculty members, teachers, and to all my colleagues. A 31-year-old female patient was brought to the emergency department in gasping state. Immediately we started oxygen at the rate of 10 liters per minute by oxygen mask. Monitors was immediately attached, which showed pulse of 113 per minute, blood pressure of 80 by 42 millimeter of mercury in supine position. Saturation of the patient was 72% on 10 liters of oxygen, and the blood sugar was 113 mg per dl. Patient's IV lines were secured and every samples were withdrawn. In our emergency department, we assess all the sick patients according to the ABCDE protocol, so we don't miss anything. As the patient came to ED in gasping state, so decision was made to immediately intubate the patient with this protocol. On direct laryngoscopy, patient laryngeal anatomy was found to be distorted and only epiglottis of the patient was visible, so it was graded as Cormack-Lehman grade 3 on grading system. An initial attempt was to insert endotracheal tube number 7 was failed. Then patient was intubated with endotracheal tube number 6 by using gum elastic bougie. After intubation, on auscultation, bilateral air entry was equal, no added sounds were present, and then patient was put on mechanical ventilation on volume control mode. Saturation of patient was now 100% on 100% FiO2. Respiratory rate was set to 18 per minute, and chest X-ray was done in the emergency department, which shows no abnormalities. Now moving to the circulation part, as the patient was receiving hypotension and in tachycardia, so we gave IV fluids and NORAD support was started. Then patient was shifted to ICU. Now I would like to invite Dr. Ayush from the Department of Critical Care Medicine for further discussion on the case. Thank you.
Good morning, respected Emeritus Chairperson Sir, senior faculty, respected teachers and my dear colleagues. I am Dr. Ayush Gupta, first year DM resident from the Department of Critical Care Medicine. This patient was transferred from emergency department to the critical care for the further management. The re-evaluation was done according to the ABCD protocol, where the A is AFA, which was already secured by the emergency department with 6 mm curved polyvinyl chloride endotracheal tube. On auscultation, bilateral air entry was present, and patient was attached to the mechanical ventilatory support. On the volume control mode, tidal volume was set as according to the predicted body weight, that is 380 ml, and the respiratory rate is 20 breaths per minute. Positive end expiratory pressure was set 5 cm of water, and the fractional inspiratory oxygen or FiO2 100% initially, and then tapered to target saturation of 90 to 95%. And high peak airway pressures alarm were observed, so troubleshooting of the ventilator was done to broaden the alarm limits. Patient was nebulized with the salbutamol and the budesonide. For the sedation, we use analgo sedation protocol, in which we use propofol 75 microgram per kg per minute, and the remifentanil was set for 0.25 microgram per kg per minute. For the paralysis, cis-heterogeneum infusion was started at the rate 1.1 milligram per kg per hour. For the circulation, the heart rate was 124 per minute, blood pressure is 90 by 50 millimeter of mercury, and the mean arterial pressure is 55 millimeter of mercury. Saturation is 100% on 100% FiO2. Fluid was started according to the goal-directed fluid therapy, and the assessment of the fluid was done by the point of care ultrasound, in which we measure inferior vena cava distensibility index. Monitoring was attached, and the urine output, heart rate, and the ABG samples were set. And for the point of care ultrasound report, lung ultrasound shows normal study, and the heart ultrasound shows IVC distensibility index more than 18%, suggestive of fluid responsiveness. So this is the proforma which is used in our critical care department for the point of care ultrasound. Left side is the heart ultrasound form, showing the IVC distensibility more than 18%, showing hypovolemia, and that is fluid resuscitation is required. And the right side shows the lung ultrasound, which is showing the normal study. For the further management, fluid resuscitation and the inotropic support to target the mean arterial pressure of more than 65 mm of mercury. Endotracheal tube care was done, sepsis screening, the culture of the endotracheal tube secretions was sent, and the mechanical ventilation observed that the raised peak airway pressure due to the small diameter of the endotracheal tube. Nutritional support was started with a rice tube feeding as a trophic 700 to 1000 kilocalorie per day. And for the further management, for the ENT department, for the history of difficult intubation due to the distorted laryngeal anatomy, and the respiratory medicine for the respiratory distress. Now I would like to invite Dr. Shivi Mathur from the ENT department to take forward this case.
A very good morning to Emeritus Chairperson, sir, dignitaries, senior faculty members, teachers, and my fellow residents. Now, once the patient was stabilized and intubated, a detailed history was taken from the family, the informant being the husband. So, our patient is a 31-year-old female, resident of Dausa, Hindu, married, and a homemaker who had complaints of difficulty in breathing since 1 year and change in voice since 1 year. As per the husband, she was apparently asymptomatic 1 year back when she developed difficulty in breathing, which was insidious in onset and gradually progressive in nature.
Hold on, just hold on. Why this history was not taken by the Department of Emergency, the first person who admitted this patient? You are taking this history on referral. Was it not the duty of... They should have told this. I know stabilization is most important in acute conditions, but after that, some history has to be taken. If not from the patient is not able to or she is not able to speak, then their attendants.
The history was taken by emergency department.
You should have told
They gave us the primary history. The critical care
I know you must have taken, but you should have documented it. No? The first one, Suchita, you tell me.
The history was taken. There was
No, but how will you know? How other audience will know? It is the duty of the first doctor who is coming in the first contact of the patient to take this.
the stabilization we simultaneously take the history and detail also.
Sir, we may want to point out that in the CCR review, we went over this many times, and for the information of everybody, from the point of the time when the patient came to the emergency and now when the ENT people were called, is 3 hours. So these 3 hours was spent in stabilizing the patient. And we did go back and forth many times कि history पहले बोले या पहले जो किया वो बोले, and we decided on this format.
The difficulty in breathing was insidious in onset and gradually progressive in nature. That is, she was able to do her household chores initially, but now had to take frequent breaks due to difficulty in breathing. Her complaints aggravated in the supine position and while talking, and it was associated with dry cough. For the same, we consulted a local doctor and she was diagnosed with recurrent laryngitis on 3 different occasions. She was prescribed with antibiotics and supportive treatment for the same, and her symptomatic relief was temporary and her symptoms reappeared. Now, she also had a change in voice since 1 year, which was insidious in onset with a hoarse character. That is, she also had progressive vocal fatigue. That is, initially she could comfortably speak up to 10 sentences. Later, she had difficulty to even speak 10 words together. It was also associated with dry cough and a constant urge to clear her throat. There were no diurnal or seasonal variations, and change in voice was not relieved by medications. Her Garba score could not be assessed as she was intubated. Now, coming to the negative history, there was no history of fever, throat pain, blood in sputum, or referred pain to the ear. There was no difficulty or pain while swallowing, no history of nasal obstruction, nasal discharge, or reduced hearing, no history of trauma, chest pain, night sweats, or retrosternal burn. There was no history of vocal misuse or vocal abuse, and no known history of allergies. Coming to the past history of the patient, there was no history of comorbidities, no history of tuberculosis or contact with a tuberculosis positive case, no history, no significant history, surgical history, and no history of prolonged hospitalization or intubation. Coming to the personal and family history, she had a mixed diet with significantly reduced appetite, normal bowel and bladder, and adequate sleep. She was a chula worker for the last 10 years with no history of smoking or tobacco consumption, no history of factory or chimney exposure, and there was no history of alcohol abuse. There was no significant menstrual or obstetric history and no significant family history. So to summarize, we have a 31-year-old female, homemaker, non-smoker, non-tobacco chewer, who presented to the emergency room at Mahatma Gandhi Hospital in a gasping state with the chief complaints of difficulty in breathing and change in voice since 1 year. Now, can any one of you think of any possible differentials on the basis of the given history? On the basis of the given history, we can classify the differentials into localized causes, that is involving the upper respiratory tract, or systemic causes involving the cardiorespiratory system. Now we can divide the localized causes into inflammatory causes, tumors, or neuromuscular causes. Now on the basis of the given history, acute causes are unlikely as there was no history of fever and symptoms were not fully resolved on taking antibiotics. Also, the patient did not have any known allergies or history in the past, therefore allergic or immune-mediated causes are unlikely. Now, neuromuscular causes include vocal cord paralysis, which can be evaluated on a laryngoscopic examination and cannot be ruled out on the basis of the history alone. And coming to the tumors, they can be either benign or malignant, and the respective causes are enumerated on the screen. Now, as there was no history of prolonged intubation or prior hospitalization, an intubation granuloma is less likely. Now, malignancy, which can be supraglottic, glottic, or subglottic, and these cannot be ruled out on the basis of the history alone. Coming to the general examination of the patient, the examination was done in the ICU settings in a sedated and a paralyzed state with a cupped 6 mm endotracheal tube in situ. The patient was in supine position with no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or pedal edema. The skin and hair were normal. On inspection and palpation of the neck region, the skin and laryngeal framework were normal. There were no swellings visualized and no neck nodes were palpated. The trachea was centrally placed and the laryngeal crepitus could not be elicited. Moving on, a bedside laryngoscopic examination was planned for the patient in the ICU. The nasal cavity was locally anesthetized and a flexible fiber optic laryngoscope was introduced in the supine position. We could see the endotracheal tube, the posterior part of the nasal septum, the posterior choana, the posterior ends of the turbinate, the base of tongue and bilateral vallicula were seen and were normal. The epiglottis and bilateral aryepiglottic folds were edematous. On the examination of the glottic region, the right vocal cords were bulky, edematous, congested with significant fullness, and the medial margins of the left vocal cord were irregular. Also, a bluish-purple lobulated mass was seen in the subglottic region but was not appreciated due to significant edema. Now, the original photographs of the laryngoscopic examination could not be retrieved. Therefore, this is a schematic representation of a finding. On the upper left corner, we can see the normal laryngeal anatomy, and in the given diagram, we can see the endotracheal tube in situ with the grey area showing the edema. We can see significant edema over the epiglottis and the aryepiglottic folds, with the right vocal cord being full, congested, edematous, and irregular medial margins of the left vocal cord. Also, a bluish-purple mass could be seen in the subglottic region but was not appreciated due to excessive edema. Now, since we have the examination findings, we can narrow down on our differentials. As no granulomas were seen, chronic granulomatous pathologies are unlikely. No contact ulcers or pinpoint hemorrhages were seen, therefore vocal abuse and misuse syndrome is unlikely. Also, no papillomatous growths were seen on the vocal cords, hence recurrent respiratory papillomatosis is less likely. No whitish patch or warty growths were seen, therefore leukoplakia or keratosis of the vocal cords is unlikely. And since no apparent growth was seen in the supraglottic region, we can rule out supraglottic malignancies. To further narrow down on our findings, a contrast-enhanced CT of the neck was advised and a simultaneous evaluation was done by the Department of Respiratory Medicine. I would like to invite Dr. Bhavya Mehta from the Department of Respiratory Medicine to take the case further. Thank you.
Thank you, Dr. Shivi. Good morning to respected Emeritus Chairperson, all the senior faculty members and all my dear colleagues. I will be covering the respiratory medicine part. The patient presented with the complaints of shortness of breath since 1 year, which was progressed from MMRC grade 2 to grade 4 since 2 days. And there was also the complaint of change in voice since 1 year. On examination, the endotracheal tube was in situ and patient was on mechanical ventilator support with saturation of 94% on 100% FiO2 and volume control mode. On examination, the chest movement was bilaterally equal. On auscultation, bilateral air entry were present and there was no added sound like wheezing or crepitations. On investigation, the arterial blood gas analysis was suggestive of type 1 respiratory failure and the arterial oxygen value was 48.3 mm mercury. The chest X-ray APV was done, which was grossly normal as seen in the photograph, and endotracheal tube was seen in the correct position. So what can be the differential diagnosis for the shortness of breath? So it can be the respiratory or cardiac or non-cardiorespiratory causes. Let's see one by one. The upper respiratory causes are already discussed by the ENT department. So in the lower respiratory causes, in the lower airways there can be obstructive airway diseases like COPD, bronchiectasis, asthma. There can be foreign body aspiration, tracheal obstruction. But based on the normal examination and normal chest X-ray findings, the lower airway causes were unlikely. Then the parenchymal causes can be like pneumonia, interstitial lung disease, exacerbation, lung malignancy. But based on the normal parenchyma seen on the chest X-ray, they were also unlikely. Then in the third is the vascular causes. There can be the pulmonary embolism, thrombosis or pulmonary artery hypertension. But there was no history of any risk factors, no history of hemoptysis, no resting hypoxemia. So vascular causes were also unlikely. And last is the pleurine chest wall causes. There can be pneumothorax, pleural effusion, fractured rib, but they were excluded based on the normal chest X-ray. Then there can be the cardiac causes. As the patient was already in hypotension state, the cardiac causes can be considered as a differential diagnosis. And in the non-cardiorespiratory causes, there can be psychogenic dyspnea, acidosis, but patient was non-obese with normal hemoglobin and normal pH. So non-cardiorespiratory causes were also unlikely. So in this patient, based on the shortness of breath and change in voice, the differential diagnosis can be narrowed down to mainly the laryngeal neoplasm, mediastinal mass, mediastinal fibrosis, and left atrial enlargement. To accurately diagnose the underlying cause, we advise the contrast-enhanced CT scan of the neck and chest, and it will be described by Dr. Kartikay from Department of Radiology. Thank you.
So contrast-enhanced CT of the neck is done with IV contrast administration with the patient in the supine position. The patient is scanned from the frontal sinus to the aortic arch. Plain and contrast-enhanced images are taken with a non-ionic, water-soluble, iodinated contrast 1 to 1.5 ml per kg at an injection rate of 2.5 to 3 ml per second. 5 mm slices are taken and reconstructed into 0.6 to 5 mm sections. Multiplanar reconstructions are made and assessed in the bone and soft tissue windows. In the first image, we can see the axial section at the level of the vocal cords. Here we can see a minimally enhancing soft tissue density lesion along the right vocal cord, and there are diffuse edematous changes. Endotracheal tube and Ryle's tube are seen in situ. In the second image, the axial section is at the level just below the vocal cords at the level of the precoid cartilage, that is the subglottic region. Here we can see a minimally enhancing lesion as well. So there is subglottic extension of the lesion. Diffuse edematous changes were also seen in the epiglottis. The sagittal section of the neck shows diffuse edema and secretions in the naso- and oropharyngeal airway. To summarize, there is a minimally enhancing soft tissue density lesion in the right glottic region with subglottic extension. Diffuse edematous changes with secretions are seen in the supraglottic, glottic and subglottic regions. There was no infiltrating characteristic of the lesion seen. There was no lysis or sclerosis of any laryngeal cartilage. No significant adenopathy or no calcification was seen within the lesion. Based on these findings, the possibility of a benign lesion appear more likely. Differentials include benign inflammatory laryngeal lesions, which include polyp, or benign laryngeal tumors, which include laryngeal papilloma, schwannoma, or hemangioma. A contrast-enhanced CT of the chest was also done. There was no hilar mass, no mediastinal fibrosis, or enlarged lymph nodes seen. Now I invite Dr. Garima Katewa, Junior Resident, Department of ENT, for further discussion of the case.
Why do you say hemangioma? There is no enhancement.
So there was minimal enhancements, and hemangiomas can have proliferative as well as involuting phases. So in proliferating phases, there is avid enhancement of the lesion, whereas in involution phases, the enhancement is minimal.
Thank you, Dr. Kartikay. Good morning, Emeritus Chairperson, sir, senior faculty, teachers, and colleagues. I'm here to take the case further. Now, coming to the differential diagnosis that we had, after the radiological expert comments, we can easily rule out malignancy. So then, the provisional diagnosis that we get is the space-occupying lesion in the glottis extending to the subglottis, probably a benign laryngeal tumor. So to manage this patient, our aim was first to secure the airway by the tracheostomy, since the ventilation was not adequate and the peak pressures were high. After that, our aim was to excise the mass lesion and get a vocal cord rehabilitation. The blood investigations of the patient were done, which were within the normal limits. The pre-op workup of the patient was done, and pre-anesthetic optimization for surgery was done. The written and informed consents by the patient and the relatives were taken for tracheostomy as well as microlaryngeal surgery. These are the instruments which were used in our procedure. So to begin with, the first procedure that we did was tracheostomy. In this, we can see the below U-shaped mark is the suprasternal notch. The above rectangular marking is the cricoid cartilage. The area for tracheostomy was between these two landmarks. First, we take an infiltration and we infiltrate the area with 2% lignocaine and adrenaline. After that, we take a knife and we give a horizontal incision. Since ours was a planned tracheostomy, therefore we preferred a horizontal incision, which is cosmetically better, as the incision can be later on. It can come in the neck creases. Therefore, we prefer a horizontal incision in cases of planned tracheostomies. Once the incision is given, we take retractors and forceps and we gently dissect the strap muscles from the medial to the lateral side in order to reach the trachea. Once we are sure that we've reached the trachea, we palpate the tracheal rings. Then we remove the superficial fascia which is present on the trachea. As we can see, the dissection is done layer by layer. After that, we take a needle in which we take lignocaine and we puncture the trachea. So here we are seeing that we are removing the final fascia layer which is present over the trachea. Once it's done, we take the syringe and we inject the lignocaine in the trachea. We gently pull it out, and when we see the air bubbles coming in the syringe, we are sure that we've reached trachea. After that, we take the knife and we give an incision between the second and the third tracheal rings, which is the preferred side. After the incision is given, we take a tracheal dilator and we gently dilate the incision which is given. This is to get a better area to insert the tracheostomy tube. So here we are seeing that we've given the incision and we've dilated the tracheal rings. After that, we take a deflated, lubricated tracheostomy tube and we insert it within this area which we've created. Once the tracheostomy tube is in place, we inflate the bulb and we connect the tracheostomy tube to the ventilator settings, and then we secure the tracheostomy tube in place by tying it around the neck of the patient. After tracheostomy, our second surgery to be performed was microlaryngeal surgery. This video shows the setup which was done for the microlaryngeal surgery. So here we see the patient is placed in the boy's position, which is extension at the atlanto-occipital joint and flexion in the neck on the chest. After that, we insert the Clesencer's microlaryngoscope in the mouth of the patient. Once we are sure that we are able to see the glottis, then we suspend it with the suspension laryngoscope in order to make our hands free for the surgery. In our patient, we could not easily see the whole view of the glottis once the laryngoscope was introduced, as the larynx of the patient was anteriorly placed. So we had to do a maneuver in which we provide external compression on the larynx and then we secure it with a velcro. It was not available with us, so we used a roller bandage to tie it around the patient along with the OT table in order to have a better view of the glottis region.
After a good view, we started with the microlaryngeal surgery. So here in this video, we can see that a bluish globular mass was seen inside the subglottis. So to begin with, we took a cold steel instrument, a blunt cold steel instrument, and we ran it around the borders of the mass. This was done in order to see that the tumor is attached to the structures multiply or from a single side. Once we were sure that the tumor is only attached to the right vocal cord in a pedunculated form, we gently pulled out the tumor from the subglottic region to the glottic region. This was done in order to do the further management. Now, since radiology had already ruled out the malignancy, therefore we were sure that this is not malignancy. So we did a piecemeal dissection of the tumor because of the big size of the tumor. The bleeding was there, but it was maintained and managed by adrenaline-soaked patty in order to control the bleeding. So here in the video we are seeing that slowly we are removing the mass, the tumor in piecemeal dissection. So we are using the micro forceps for this and the micro scissors which were introduced, and the piecemeal dissection of the patient was done. Once it is completed, we take an adrenaline-soaked patty and we rub it around the operating area in order to assure that we have a bloodless field. So here we are seeing that we've controlled the bleeding with the patty, and after this we can easily see that the vocal cords were absolutely free of any growth which was present. So here we are seeing the free margins of the vocal cord which was free of any growth, and smooth vocal cords could be seen, and we can even see the subglottic region which was free of any mass. These are the modalities which we can use in our day-to-day practice for microlaryngeal surgeries, that is laser, ablation and debrider. The post-operative treatment given to the patient was steroids, antibiotics, anti-inflammatory, analgesics and other supportive measures. The tracheostomy tube for the patient, the decannulation was done on the third post-operative day. For this, on the second post-operative day, we did strapping of the tracheostomy tube in order to see that if the patient can maintain the airway without the help of the tracheostomy tube. Once we were sure after 24 hours of observation that the patient could normally breathe, therefore on the third post-operative day we did the decannulation of the tracheostomy tube. And this was actually an achievement for us because the patient came in a gasping state, and on the third post-operative day we could have the patient breathing normally from nose without any distress. This video shows the post-operative 2-week follow-up of the patient. In this we can see the vocal cords are free of any mass and they are bilaterally mobile, but the right vocal cord slightly shows fibrosis, which usually happens after the microlaryngeal surgeries. Now I would like to call Dr. Shreya Mittal from Department of Pathology to further analyze the mass which was sent to the Pathology Department for investigation. Thank you.
Thank you, Dr. Garima. Good morning, respected chairperson, sir, senior faculty members, seniors and my colleagues. So starting with the gross examination, we received several tissue bits from glottic and subglottic areas, which was collectively measuring 1.8 by 1.6 by 1 centimeter, and the tissue was entirely submitted. So on microscopic examination, as in the first slide, we see these arrow marks showing the stratified squamous epithelium, and the second section showing the hemosiderin-laden macrophages along with the chronic inflammatory infiltrate. The third image is showing the hemorrhagic areas along with the fibrin exudates, and in the fourth image it is showing the dilated vascular channels. So features are suggestive of benign vascular lesion favoring cavernous hemangioma. Thank you. Now I would like to call Dr. Garima to continue further.
Thank you, Dr. Shreya. So by this time we have a final diagnosis, which is cavernous hemangioma of the right vocal cord. These are some basic pathologies that we are dealing in ENT in our routine life for microscopic laryngeal surgeries. The first one shows the large polyp. Second is the granuloma, which is generally after intubation. The fourth picture here shows the malignancy, and this is recurrent laryngeal papillomatosis. This is the hemangioma, which is a rare presentation, and this was our case too. So hemangiomas in general are classified into two forms, be it the infantile and the adult. The infantile are the more common and present in the subglottic region. The adult hemangiomas are less common and they are present generally in the supraglottic and the glottic region. The infantile hemangiomas are generally missed. The diagnosis is missed because they have a procedure known as the involution. That means that by the age of 5 years, generally the hemangiomas are resolved itself by the treatment of steroids, which is given for normal treatment of laryngitis to the children. So, this was the first case of adult hemangiomas which was reported in the year 1979. Since then, from 1979 to 2023, only 23 cases of adult hemangiomas have been reported in literature. And we can see that the common presentation of these cases was hoarseness of voice. This is the first case in publication of adult hemangioma with the respiratory distress. It was reported in the year 2020 and the patient had come to the emergency department in a gasping state. This was similar to our case and ours being the second is under process of publication. Now coming to the paradigms. The fortunate paradigms that we had in our case was, since it was the adult hemangioma which generally undergoes fibrosis, so we were lucky to have less bleeding in the field. The tracheostomy procedure was a blessing in disguise for us because since there was no tube through the mouth orally, therefore we had a proper field for operating, so it was a blessing for us. There was no concurrent lung pathology which can be present in cases of respiratory distress, and also the critical timeline, which means that from the presentation of the patient to the emergency department till the management which was done of the patient, it was done within the span of 12 hours, which is itself an achievement, and because of the multidisciplinary team of our hospital, we could easily do that. The unfortunate paradigms were, the change in voice was repeatedly misdiagnosed at the other centers where the patient was going again and again and was only treated for laryngitis. Nothing else was suspected. Then the superficial clinical assessment, it also led the patient to the gasping state. Why this case? Due to the rarity of the laryngeal hemangiomas would seldom be considered in the differential diagnosis, and due to atypical presentation of respiratory distress, we can easily misdiagnose. As we all know, even if somebody thinks of adult hemangiomas, the first thing comes into mind is hoarseness is the basic presentation, but here it was the respiratory distress. So the take-home message is, long-standing change in voice, it is a cause of concern and there should be thorough evaluation which has to be done. The first step towards the management of the pathology should be, first the patient stabilization, then the comprehensive evaluation, and then the prompt intervention. Good backup has to be there in form of manpower and instrument, which we were lucky enough to have, and multidisciplinary team coordination has to be there, which was seen perfectly in our case. This is the video of the patient after 1 month follow-up. Though there is slight hoarseness in the voice is near normal. This hoarseness is basically because of the fibrosis that has occurred on the right vocal cord, but we could achieve a near normal voice of the patient after 1 month of follow-up. So in the end, I'd like to extend my gratitude towards the management of Mahatma Gandhi Medical College and Hospital, the CCR Review Committee, the collaborating departments, Department of Emergency Medicine, Critical Care, Respiratory Medicine, Radio Diagnosis and Pathology, the supporting staff, and the patient and her relatives for letting us do this case and share it with you all. Thank you so much.
What will you do? Yeah, wonderful presentation. What will you do to further improve the hoarseness of voice in case of scar?
Sir, complete rehabilitation of the voice might not happen. There will be slight, and patients are generally counseled after the microlaryngeal surgeries that there might be a chance that you will not have the similar voice as you had before.